So we'll talk about stroke. The definition of stroke is sudden onset of a neurological deficit from a vascular mechanism. Males are usually more affected than females. It is seen more common in the elderly. Coming to types of stroke, there are two types: ischemic stroke and hemorrhagic stroke. Ischemic stroke is the more common one. 85% of the cases are ischemic stroke. Hemorrhagic stroke contains subarachnoid hemorrhage and intracerebral hemorrhage. Coming to the risk factors, it includes hypertension, diabetes mellitus, hyperlipidemia, alcohol usage, smoking, family history of stroke, trauma, old age, males, black ethnicity, obesity, drugs. Ischemic stroke. The etiology includes ischemic stroke is due to the sudden occlusion of an intracerebral vessel which reduces the blood flow to the brain area supplied by that vessel. It can be an in situ thrombus or an emboli, previously diseased vessel, atherosclerotic plaque and the rupture, dissection of large vessels are the components of the in situ thrombus. Emboli is usually from a distant organ like heart. Common causes include thrombosis, which is in situ from the small vessel thrombosis or large vessel thrombosis. Embolic can be artery to artery like carotid disease or aortic disease. Cardioembolic includes MI, valvular like mitral stenosis, infective endocarditis, atrial fibrillation, ventricular dilatation, cardiac myopathy. Uncommon causes are hypercoagulable states, protein C deficiency, protein S deficiency, APLA syndrome, antithrombin 3 deficiency, malignancy, polycythemia, sickle cell disease. Drugs like amphetamine, cocaine, and TB. One thing to be noted is cardioembolic and uncommon causes can usually occur below the age of 40 years. Pathophysiology. Mainly there is ischemia and infarction. There is a thing known as ischemic penumbra where the infarcted area is surrounded by an ischemic area. Earlier or the faster the treatment is done, we can save the ischemic area going into a infarcted area. So the area surrounding the infarcted area is known as ischemic penumbra. So the infarction occurs by two methods: necrosis and apoptosis. In case of clinical features, the initial symptoms include numbness, weakness, contralateral paralysis of the limbs and face, headache, dizziness, and visual blurring. In case of hemorrhagic stroke, there is sudden severe onset of headache, vomiting, and loss of consciousness or coma. Neurological deficit depends on the vessel blocked and the area of brain involved. In case of middle cerebral artery, contralateral hemiparesis, hemianesthesia, dysarthria, contralateral homonymous hemianopia, aphasia, or apraxia and sensory neglect are the features. In anterior cerebral artery, contralateral hemiparesis, which is worst in leg than arm, urinary incontinence, confusion, poor judgment, mutism are seen. Postcerebral artery shows contralateral homonymous hemianopia, unilateral cortical blindness, memory impairment. Internal carotid artery shows ipsilateral blindness, which is variable, and features of MCA territory stroke on the opposite side. Vertebrobasilar system shows unilateral or bilateral cranial nerve deficits, truncular limb ataxia, spastic paralysis, crossed sensory and motor deficits, impaired consciousness, coma, and death. Investigations include CT scan head. It is the investigation of choice. It is cheaper compared to the MRI. It can be done easily and the hemorrhage can be found easily. In case of MRI, it is more sensitive towards infarct of the brain. CT angiogram and MR angiogram are the other methods of the investigation. Carotid artery and vertebral artery and Dopplers, ECG and echo. Blood tests including urea, creatinine, random blood sugar, total blood count, lipid profile, coagulation, toxicology are done. The treatment includes initial management where we have to assess the airway breathing and circulation, secure airway, monitor oxygenation, ventilatory support. The main treatment starts from here. There is the antithrombotic treatment. we use antiplatelet agents like aspirin and clopidogrel. The loading dose of aspirin is 325 mg. Later, we have to give 150 mg lifelong. In case of transient ischemic attacks, as said earlier, dual antiplatelet therapy is done, which includes clopidogrel and aspirin. Aspirin is to be given immediately after diagnosis. Two benefits are it prevents the clot extension and also prevents recurrent thrombosis. One thing to be noted is clopidogrel and aspirin both combined is not necessarily lifelong. Aspirin itself is efficient in the long life. Anticoagulants like low molecular weight heparin and warfarin are used. Initially, IV heparin can be used and later it can be moved to oral warfarin. It is more useful in cardioembolic etiology. IV thrombolysis is the first line of treatment in 2 hours, 2 to 3 hours. Recombinant tissue plasminogen activator is used. The contraindications are high BP, trauma to the head, prior surgery in the last 3 months, any bleeding in the GIT. Mechanical thrombectomy is done. It is another method of treatment. Statins like atorvastatin and rosuvastatin is used. Atorvastatin 80 mg daily and rosuvastatin 20 mg daily. Supportive measures are to prevent infections. Treat the fever. Fever is detrimental usually in these cases, so fever has to be treated by antipyretics and cold sponge. Blood glucose less than 110 milligram per deciliter should be maintained. In case of cerebral edema, IV mannitol is used. Rehabilitation is counseling and make the patient early to work and early to his home so that he can continue a normal lifestyle.